Thank you everyone for joining Minnesota HIMSS today for our webinar on an analytics-driven approach in the transition to virtual care during COVID, presented by Dr. Patrick McGill. We will be recording this event and making this available to all of our Minnesota HIMSS members. If you would like to be a speaker or sponsor for a future webinar event, please reach out to us on our webpage at mn.himschapter.org. We will do a Q&A at the end of the session. Please type your questions in the question section of GoToWebinar. I am pleased to introduce our speaker today, Dr. Patrick McGill, who serves as the Executive Vice President and Chief Analytics Officer for Community Health Network in Indianapolis, Indiana. In this capacity, he provides oversight for the newly formed Office of Analytics. Most recently, he served as the Senior Vice President for Clinical Strategy, leading the product lines in the reduction of clinical variation, strategies for growth and success in value-based care. Prior, he served as the Vice President of Clinical Transformation. Additionally, Dr. McGill has special interest in clinical analytics, office workflow efficiency, and waste reduction. Dr. McGill is certified in Greenbelt in Lean and Six Sigma. Born and raised outside of Atlanta, Georgia, Dr. McGill attended the University of Georgia in Athens, Georgia, graduating with a Bachelor of Science in Chemistry. He received his medical degree from the Medical College of Georgia in Augusta, Georgia, and completed his residency at Ball Memorial Hospital in Muncie, Indiana. Thank you, Dr. McGill, for presenting today.
Thank you. It's my pleasure to be here to talk about the analytics approach that we took as we transitioned to virtual care during the COVID-19 pandemic. So I appreciate the invitation tremendously. So let me start with who Community Health Network is. Being in Indianapolis, many of you may not be familiar with Community Health Network. So we're 200 sites of care in central Indiana, 9 acute care and specialty care hospitals, many ambulatory pavilions and sites. We have about 1,000 or 1,100 employed providers and care for about 2 million patients a year. So mid-sized integrated healthcare system in the Indianapolis area. So today we will talk about the impact of COVID-19 on ambulatory visits. We will review how the enterprise-wide analytics are critical to financially successful practice, especially during this transition. We can share how Community Health Network shifted to virtual health and how we're measuring the virtual care with an analytics platform, and then, of course, save time for questions and answers. I think everybody's probably intimately familiar with COVID-19's impact on ambulatory care. Early in the pandemic, when CMS called for canceling non-urgent visits in Indiana, our governor stepped in and said, they wanted us to stop all non-elective surgery, non-emergent surgeries, close down the offices to save PPE. I think everybody was impacted tremendously. We went from, and I'll show this in the analytics in a minute, we went from almost no virtual care adoption to rapidly shifting to nearly 100% virtual care delivery in the matter of a week or two. And we advanced, 10 years in healthcare in the technology space over the course of a couple of weeks. And ambulatory care practices saw a decline of, this was a study from April actually, or data from April, saw 60% decline in visits nationwide. And I think that you could argue in some pockets it was much higher than that, even in the close to 80 to 90%. And the third bullet point is from an article in Health Affairs that shows that primary care is projected to lose $15 billion or almost 70,000 per full-time physician based on the shutdown. And so how do you recover from such a significant financial loss? especially if you're an independent primary care physician or primary care practice, much less if you're part of a larger healthcare system. Initially we saw a 92% decrease in ambulatory care visits. So we in Indianapolis, along with the other health systems in Indianapolis, pretty much shut down the entire ambulatory care structure. So what did life look like before COVID, and what work had we done? I wanted to paint a picture of where we were when COVID hit and some of the work that we had been doing. So we had been working with our analytics team and analytic partners to develop a comprehensive practice management suite of reports and analytics and insights. And this is a screenshot from an executive summary. The nice thing about this suite and these analytics is you can drill down all the way down to an individual provider. So we went into this with the notion or the idea that we wanted each provider, physician, APP, nurse practitioner, PA, that you could look at that individual, not as part of a practice, but as an individual, as if they were, go back 50 years, as if they were a standalone business, and you could see all the information around that specific practice. So that's where we had started. And we, late last year, rolled this out to all of our primary and specialty care physicians. This is another screenshot from productivity. So we're primarily driven off of work RVUs, and so we have the ability to look at p-values, how many days did they work a month, how many visits per day were they having, how many work RVUs, how many slots went unfilled, showing heat maps of when the most appointments were scheduled or high demand. And then you can see the productivity trends. And then of course, in the middle, you have to have the detail. If you've ever worked with physicians, the first thing they're going to want to see when they have a question is show me all the details, show me all the encounters, and that's what we show them. And then at the bottom, we give them the opportunity for scenario planning. So if they want to increase the number of days that they work, what does that do to their productivity? If they increase the number of visits per day, what impact does that have? So they can slide up and down to do different scenarios to adjust their productivity. So as you can see, the analytics suite that we built was in the old world. It was all face-to-face driven, face-to-face visit driven. It was very productivity heavy. This is the world that we used to live in. And I should say Indiana, and specifically Indianapolis, is still predominantly fee-for-service. We achieve probably 98% of our revenue from fee-for-service. So we have not transitioned to many parts of the country, Minnesota or Minneapolis being one of them, to a value-based care payment system. We're still primarily fee-for-service. We've started down that path, but not to the degree that other parts of the country have. We focused on access. So how many hours were people working? How long did it take to see a new patient? And how many new patients were you seeing? So I show this because this was our virtual care dashboard before the COVID pandemic hit. And you can see in the center, our virtual care visits, and this is for all 1,200 providers, was essentially non-existent. So we were seeing less than 100, more like 50 of telephone or telehealth visits. And you can see the blue sliver is video, which is, you can't even see on the graph. It's so few. So we had about 3 providers that were doing video visits before the pandemic. And then in early March, you can see the numbers start to shoot way up, obviously, as things started to transition. So we went from non-existent virtual care, like I said, to almost 100% virtual care, and had to pivot the analytics to support that. So what did we do early in the pandemic? COVID comes, we make this transition, and we had to shift our analytic approach as well. So we shifted to virtual care. We shifted to on-demand virtual care, on-demand visits. We shifted to scheduled follow-up visits, whether it was video or telephone or other modalities. We made that shift just like everybody else did. And we shifted our analytics as well. So this is another screenshot showing that we were able to break down telehealth, telephone, and we define those as 2 different. Telehealth was an encounter type that could be either telephonic or video. depending on if the provider was able to make a connection with the patient. Maybe they had connectivity issues and they started as a video and had to convert to a telephone encounter, or maybe we wanted to separate out how many visits were purely telephone that never even attempted to be via video, and then how many visits were actually completed as a video visit with that face-to-face video interaction, and what percent were completed. So we knew how many were scheduled as each type, and then how many were completed. And so you can see, I intentionally put the date range on the screenshot from March to July, because you can see the ramp up of telephone and telehealth, and then the ramp up in early April with video, and I'll explain that in a second. And then over time, as things have started to reopen in late June and early July, you can see the decline of the video visits as more face-to-face and visits have restarted. So early in March and April, you see the quick ramp up of telephone and telehealth visits, and the slow, the 2-week lagging slow increase of video, because we had not, because of our previous low adoption of video visits, we did not have a robust video technology in place. We had many different point solutions, but we were struggling with, we're on Epic. We were struggling with Epic video visits. We were struggling with other video visits to get them up and going and be stable and consistent connection. And so you can see many providers just defaulted to telephone, didn't even try to do video. Once we had a stable platform and we could educate and get some adoption, also get the hardware in place, the video cameras and other laptops and desktops that people needed, then you see an increase in the video adoption. People wanted to know daily versus weekly. So were we seeing an increased number of video visits or virtual visits on Mondays versus Fridays? Was there opportunity for weekends? Obviously, if you're not dependent on the four walls of an office, you have a lot of flexibility in when you can perform these visits, before work, after work. All the attributes and the reasons to shift to a virtual care platform. We wanted to dive in and understand if there were trends or insights into when people desired these visits. So on the top half of this graph, we're able to break it out by day of the week, and you can see there's a natural trend down. Mondays are highest, and then Fridays tend to be a little bit lower, and then of course the weekends still tend to be non-existent. On the bottom half is the total volume of video visits or virtual visits by week. And so again, to the point that I was making earlier, we see this increase, and then we see this kind of slow decline as time has gone on, as face-to-face visits continue or restart. One of the nice things that we wanted to do, or one of the asks that people had, was, well, tell me where these patients are coming from. Are we seeing patients in a geographically diverse manner, or is it concentrated around the practice? So this is a high-level screenshot at the network level. However, we have this data down to the individual provider level. So each individual provider can see where their patients are that have completed a virtual visit. And so it does, when you're looking at market share and growth, it actually does give you some valuable insights to understand truly where the location of the patients who come for face-to-face visits, or the outreach of the virtual care patients as well. So I put this in the category of, it's kind of a cool, nice to have. It gets you some oohs and ahs when you're in a presentation or a meeting, but it does also have some valuable insights to understand truly where your patient population is coming from, whether it's in person or virtual. One of the things that we struggled with, probably from a technology standpoint, also from a patient education and from a provider, was completed versus canceled. So in the beginning, we saw a lot of canceled appointments for many different reasons. Schedules were changing. People were being reallocated into the hospital. Patients' needs were being taken care of without an appointment through portals and such. And so we wanted to see how many visits were completed versus canceled. And for the ones that were canceled, I'm sorry, for the ones that were completed, what types of visits were they completing? So even though we dramatically reduced our ambulatory visits, there still were some ambulatory visits that we still had to do in person. OB, late-term OB visits needed to be done in person. Some urgent or high-risk, critical follow-up from the hospital needed to be done in person. Some acute illness types of visits needed to be done in person. So we were able to track how many were able to be done via video visit, how many completed, and then still how many were done, what visit types were done in person, completed in person. And then on the bottom half of this graph, we show for canceled appointments, what was the reason? Did the provider cancel? You'll see the orange bar on the bottom graph is canceled due to COVID-19. So we very early on instituted a cancellation reason of either COVID-19, or then later we added a fear of COVID-19. So if a patient was canceling because they were afraid to come back into the system as we started to slowly reopen, we wanted to know that. And so you can see on the bottom, like I said, the orange bar represents the cancellation reason for COVID, and we wanted to be able to track that. And COVID could be anything from the patient had COVID, or we suspected they had COVID, and so we didn't want them coming into the office. Maybe they had gotten admitted. Maybe we were redirecting them to the ER for a higher level of care. It could be anything related to COVID-19. Maybe they'd been exposed, and again, we didn't want them coming into the office. And again, you can break that down on the right-hand side by a further reason for cancellation. This is what I was referring to as the fear of COVID cancellation. So we added this later in May as we started to reopen. Very few sites started restarting elective surgeries. We added this fear of COVID. We wanted to get an idea of how many patients would not come back for their surgery, come back for their procedure because they were afraid of the healthcare system or afraid of getting COVID or contracting COVID when they came back. And we were able to break this down by how many what types of visit types. So were these routine office visits? Are these new patients who didn't want to come back? What specialties? So you can see in the bottom left, pulmonology and oncology is, almost 20% of patients didn't want to come to their visit because they were afraid. Obviously a very vulnerable population, you would expect that. In the middle, we broke it down by age. So obviously there's higher incidence of elderly patients who were afraid to come in, afraid of getting COVID. We broke it down by race, gender, and then we could see the trending cancellations, and we added the number of days between cancellation and the appointment date. So is this somebody who's scheduling, a week or two out and then thinks about it and gets scared and doesn't want to come in, or these people that are scheduling same days and then not coming in because of fear of COVID. So you can see the average time between schedule and the appointment is 7 days. So this gave us some insight into what types of patients, what departments, how could we direct further patient education, further marketing campaigns to say, yes, we're safe, we have appropriate PPE, we have these precautions of cleaning. It led us to add, as many people and many systems in the country did, add marketing and education on the doors of our buildings to say these are the precautions that we're taking in terms of cleaning the rooms and masks and everything else as people were coming back. One of the questions that our leadership asked was, are we, as we shift to virtual care, are we unknowingly, do we have a disparity between race and ethnicity? Are we disadvantaging certain races who may not have access to technology or reliable internet or smartphones? And so we did that. We looked at telehealth visits, telephone and video visits. The blue and the orange line represent, those are two counties. So Marion County is the city of Indianapolis. Hamilton County is north of Indianapolis. We measured this out for the 9 counties that represent the central Indiana area, but these two represent the largest population within the Indianapolis metro area. So Marion County is about 1 million people. It's Indianapolis. Hamilton County, like I said, is a little bit north of Indianapolis. And you can see the breakdown by race and Over on the right-hand side, we broke it out or we compared it to the census data. Granted, this is 2010 census data was the most up-to-date that we have, but we were able to break it down to see if there was a significant variation between who was utilizing a virtual care by race and ethnicity and the population. So a rough estimate to get an idea of is there a inherent bias towards the technology or against the technology. It's great to shift to virtual care, but not if every patient doesn't have access to it. So where do we go forward? Looking here with ambulatory visits, one of the questions that many of our providers were asking is what percentage in the future or moving forward, what percentage should be virtual? So we've come, like I said earlier, we've come a long way in shifting the U.S. healthcare system to adopt a lot of these technologies. How much of it will stick? And by the graph I showed earlier, we're on the downward trend. We're losing traction on the stickiness. And so many providers said, well, show me what types of visits. If I told you these types of visits could be done virtually, what percentage of my visits that I perform does that represent? So we're able to break this down by specialty and by department and provider to say, we estimate that, 30% of your visits could be done virtually. And so I've given an example here. If you look at primary care and you choose established patient visits and follow-up, approximately 63% of those would fall into the eligible for a virtual visit. Now, we know that that's probably pretty high. There's a patient desire to come in. They still, at least in Indianapolis, they still want that face-to-face interaction. So this is just showing kind of what the future or what the potential pool of visits that would qualify for virtual or could qualify for virtual is in that ecosystem. So that's all I have on the virtual care. I wanted to speak for a few minutes on kind of some of the analytics that we built related to elective surgery, the pause and the restart, and understanding where we stood with that, because in a lot of ways with the COVID shutdown, these things went hand in hand with the shutdown of elective surgeries and ambulatory care. So we had a desire to understand the financial impact of stopping elective surgeries. And so we have an analytic suite of tools that shows by procedure, by provider, by department, based on last year's financial performance, what the impact would be. And so you can start to see what the backlog of cases can be and how do you work that backlog of cases down to get people scheduled for the future. Which surgeries to restart? When we restarted elective surgeries, we had limited capacity in the OR. So we really, if you take the emergent surgeries out or the near emergent surgeries out, and they're truly elective, what surgeries should you restart from a revenue standpoint? So we were able to slice out, obviously, as you would expect, many of the joints and robotic surgeries represented the highest percentage. But what this graph shows is the blue bars represent 80% of the previous year's revenue. So if you redid all of those or restart all of those cases, that would get you to 80% of last year's. And as many health systems were struggling financially, and obviously surgeries are the life, for many are the lifeblood of the system performance, it was important to understand where those, what the opportunity is for many of these cases to restart. And then finally, estimating the impact of ramp-up plans. And so we built an analytic tool that allows, and you'll see in the bottom left-hand corner, some scenario adjustments. So we restarted elective surgeries in May. We didn't go right out of the gate at 100%. So we started at, we had targets of 30 or 40% and then go up to 60% in June and 70% in July, et cetera. And so what we built was a scenario tool that you could adjust. If I got to 70% in June, 80 in July, 95 in August on down, what would that do based on last year's revenue? And you can completely adjust those all the way down from 0 to 100. So if this current surge, continues to take hold and we have to slow down, we're able to plug in, what the percentage of elective surgeries would be and see how that's going to impact us from a financial standpoint. So it truly is a elective surgery scenario planning tool. So in summary, enterprise analytics can greatly assist with the transition and types of care from face-to-face to virtual, and telephone and many other things. Having that enterprise view allows you to make some targeted strategic decisions in the midst of a pandemic. And we were lucky that we had this enterprise suite ahead of time, and then it just required some small pivots to incorporate the virtual care. Again, I think it goes without saying, having provider level data is the key to the adoption, and especially with opportunity assessments. We know that every practice is a little bit different. Many providers, physicians, nurse practitioners, others practice a little bit differently. Patient demographics are different. Geographic areas are different. And so having that provider level data is a key to, driving the adoption of many of these tools. So where are we with next steps? Understanding the hybrid practice to determine the correct percentage of in-person versus virtual care. That's a hot topic, as we don't want to just arbitrarily lay out a percentage of virtual. We want it to be right. We want it to be patient-centered. So what does that look like? How do we develop tools to allow people to practice in an enjoyable way? The other thing is incorporating quality and patient experience data into these dashboards. So another dashboard that I didn't show was there was an assumption that with virtual care during COVID, we were providing more quote unquote Band-Aid type care. We were just getting people through, getting their medications refilled, getting them through their acute need, but we weren't really addressing quality gaps and, ordering things like mammograms or A1Cs for diabetes. And so we did an analysis that showed the impact of quality performance, but it was separate. It wasn't down to the provider. And then we also did an analysis that showed how many orders per virtual encounter versus an in-person encounter, how many orders for labs and imaging. And it was quite the opposite of what you would think. We actually ordered more labs and more images in a virtual encounter than we did in a face-to-face. And being a family physician myself, my gut reaction is that's due to people's uneasiness with virtual care. And so they're ordering more so that they can be sure, because they can't physically see the patient, physically lay hands and reassure themselves about the diagnoses. And so they're relying more on diagnostic testing to reassure them on the diagnosis. But, your gut feeling would be it was the opposite, that people were ordering less, but it actually, for us, it turned out to be more. So those are some of the next steps that we're looking at of how do we live in this new world of COVID. I think we're all agree that COVID is going to be around for a while, and we need to learn as a healthcare system to deal with it and have it as part of our daily life. And so we've had to adjust our analytics and our system to meet that quote unquote new normal. So I'll stop there, and then we can entertain any questions that anyone might have.
Thank you. If you have a question, please go ahead and type that in the question section, Q&A section of GoToWebinar. I'm curious, what surprised you when you completed this analysis? What surprised you the most about the data, and what was some of the large actions or changes that you implemented as a result of doing this analysis?
Yeah, one of the things that surprised me, I guess it partially surprised me, was on the one graph where I showed the real tailing off of virtual care, especially with the reimbursement for virtual care the way it is now, basically the same as a face-to-face visit. I was surprised that we saw such a dramatic, in having some other data that I didn't show, it's been pretty dramatic that people are really wanting to go back to the way it was with face-to-face, with nearly 100% face-to-face visits. So I was surprised by that because, you know, there are some inherent efficiencies with doing virtual. The second piece of it was, and I didn't have it here to show, we have some operational data that shows that, especially as we're learning to do virtual visits and virtual care, it's not just a doctor sitting in a room on a computer doing video visits. There actually has to be some architecture and infrastructure around them to make sure the patients are checked in, to do the rooming, to do the referrals. I mean, there's still, it's not just a one-stop shop. There still has to be some coordination of care around. And so I think we were all surprised to see that the cost of delivery of care didn't necessarily drop off with virtual like you might expect. But the biggest one was, you know, this just kind of push to go back to 100% face-to-face visits.
Did you track your patient portal utilization at all and see a trend or a difference over a period of time that increased the video visits, or how was your patient portal utilization prior to this?
Yeah, our patient portal utilization, or I should activation and utilization, we're in the top 10% of Epic customers. So our activation rate, our active patient user rate is somewhere in the 46, 47, 48% range. It's actually gone up with the pandemic. So it's gone up for a couple of reasons. We had some SMS text-driven campaigns to get people activated on MyChart. So if they would have a video visit and they weren't active on MyChart, we would send them a text to activate their MyChart account. We did some mini campaigns to get people activated. So I would say our patient activation and engagement rate with MyChart is the highest it's ever been. It continues to trend up. And we really had an organizational push because many of the tools that we're launching now, contactless check-in, other video visits, other features, really start with that MyChart activation.
How did you get the doctors to really buy into the tools for video visits?
The actual tool of video visits, I think it was by necessity. We struggled, like many other organizations, right out of the beginning of trying to find a common video visit platform. The one that we were using did not pan out. It was not stable. They couldn't scale to meet the demand. So we had people using FaceTime and Doximity and many other tools, which did add some complexity to the analytics, because if somebody did a point-to-point on FaceTime, a video visit on FaceTime, we were dependent on what the encounter in Epic showed. We didn't have the ability to see. So we didn't have the ability to see whether they did a video visit or they did a telephone visit. So in the beginning, our poor, kudos to our rev cycle team. They were doing 100% review on all of these encounters to make sure that they were documented and billed appropriately, whether it was a face-to-face or a video face-to-face encounter on telephone. So that was one of the things that we really struggled with, was getting adoption. We've transitioned to the Epic native video visit platform, and we have much better adoption. It's much more stable. It's integrated into the workflow. So we have been pretty happy with that transition.
And is that are you all solely measuring this then out of Epic? So these dashboards are fed out of your Epic system?
Our Epic feeds our enterprise data warehouse, which the reports are built on top of the EDW. So there's some other information that's fed into the EDW aside from just Epic data.
Okay.
So it's a combination. That's where we're able to combine financial and other information with the Epic data.
We have a question here about the specific differences between what constitutes a televisit versus a video visit.
Yeah, we had, this was another area. So if I had a crystal ball and could go back, or, a magic wand and could go back to the beginning of something that we would not do that we did, was we created a telehealth encounter or telehealth visit. And a telehealth was kind of a one-stop shop that you could do a telephone visit, you could do a video visit, you could do whatever you wanted out of this. And that created some headaches on the analytics side to truly figure out what people were doing. But to answer the question, a telephone visit would just be, like it sounds, it's just talking over the phone. No face-to-face interaction, no video, just picking up the phone and calling a patient. And then a video visit would be, just like it sounds, a video encounter either through the laptop or the phone. It could be laptop to phone, but where you can actually see the patient face to face.
What is the criteria to determine a visit type as appropriate for virtual or versus in person?
Yeah, so it's really specialty dependent. So we created that dashboard or that analytic piece to allow whoever's looking at it to go through all of the different visit types and say, I think this one could be done virtually. I think this one could be done. And so the analytics doesn't tell you which one you can do virtually. It tells you if you do if this visit type can be done virtually, which is a clinical decision, this is the percent of visits that roll up into that. These are how many you did last year or over whatever period of time. So for example, a well child check, a well child check with a physical exam and vaccines and things like that can't be done virtually. And I know there's nuances to it, but for let's just for argument's sake say that a well child check cannot be done virtually. So we would not check that one. But a follow-up rash or a follow-up visit or follow-up hypertension or diabetes, any kind of follow-up, quote unquote, follow-up visit could be done virtually. So you would check that and it would tell you did 1,000 follow-up visits last year. So, and that represents 20% of your visits. So then 20% of your visits could be done virtually, post-op surgical visits, things like that. So it allows the provider to make that clinical decision on which ones could be done virtually and which ones couldn't.
Did you collect any patient experience or feedback, or how did you measure really the patient experience with the virtual visits?
Yeah, when the pandemic started, we actually turned off our patient experience surveys. And we did that for a couple different reasons. One, as everybody knows, it was completely chaotic. You barely knew who was coming and going. And the last thing you needed was a patient experience survey to tell somebody that they were horrible when they were working, 24 hours nonstop and everybody was stressed and burned out. So we made a caregiver experience decision to not do the patient experience surveys. However, with telehealth or virtual care, we turned on a limited telehealth virtual care patient experience survey that would go out to them after, and it was a limited, I believe it was 4 or 5 questions, just so that we could, because this was new and we had completely flipped and ramped it up, we wanted to make sure that we weren't somehow, having a completely negative patient experience. And so while we turned off other patient experience surveys, we turned on the virtual care ones so that we could measure that. And the data is limited. And again, it's limited to the patients who actually engaged with a virtual care visit. It was turned on during when we had, we were experimenting and learning from technology. But overall, I would say the experiences were more positive than negative. I would not say that they were to the degree of in-person care, but it was more positive than negative. So we were measuring that on the virtual care.
If you had to do it over again or could change something, what would that be?
Yeah, the first thing I would do would be not create that telehealth encounter. I would kind of force is probably too strong of a word. I would highly encourage people to either have a telephone or a video visit encounter. And knowing that with the technology being unstable, people were having to flip these encounters on the fly. So I had it to go back and do over. We would have a more stable video visit platform, and then that would allow us to either have telephone or video visit encounter types. It would save us a ton of work on the back end, either analytic work or rev cycle work as well. If I had it to do over again, the other thing that I would do is, we were begging people for 18 months prior to the pandemic to trial and start to adopt virtual care, and really could never really get traction for many reasons. Mainly, like I said at the outset, when we pay people on work RVUs and we're completely a fee-for-service system, asking people to do something that's not reimbursed very well or not even reimbursed at all usually is a non-starter. And so we had been begging people to participate in virtual care for about 18 months before. And so we could have worked out some of the bugs, some of the kinks, worked out some of these things. Obviously, the pandemic forced our hand, and we didn't have a choice at that point. So those are the two things that I would change if I could go back and try and get more adoption. Knowing that a global pandemic was coming, I would get more adoption of the virtual care, and then not make those encounter types.
Have you started to see any normalization around the number of appointments that have come back to your clinic?
Yes, actually, yes. So we started in late June, really reopening our ambulatory clinics. We started in early June, I should say, but by late June, we were, we put kind of regulators as we went through June. But by the end of June, providers were able to schedule as many as they previously did. I would not say we're not back to 100% at all. I would say we're probably close to 60 to 70% range. By the time you put some of the other things in about the workflow within the workflows of nobody's in the waiting room, and the contact, curbside contactless check-in, the cleaning of the rooms, letting the rooms sit for a while, and everything else, it's hard to get back to your previous volume. And that's why we've baked in for elective surgeries, we probably won't get back to 100% of where we were because of all the other precautions. So we baked in that our new normal is kind of 90 to 95% of what our old normal was, with unless we do something different, like operate on Saturdays and Sundays and open up different hours. But if things stay the same, so we've kind of taken that same approach in the ambulatory setting as well. And so I would say we're probably 60 to 70%. I can tell you personally, because I still see patients one day a week, I can tell you when I was seeing patients virtually, the only question that they consistently asked me was, when can I come back into the office to see you? And so there is a huge push from patients to get back into the office as well. It's not just the providers. So I think that's one area in people's life that they want to get back to normal. They're accepting of wearing a mask when they go out to the grocery store or home store or whatever. They want to come back to see their doctor.
Thank you. Our final question is, what do you see as next steps or the next phases with analytics and virtual care for your facility?
Yeah, I think the next stage is really diving deeper into the quality and really understanding the outcomes, the quality outcomes related to virtual care. I think that will help with some of the adoption, diving a little bit deeper in with the patient experience portions as well. And if we can show, that there's no adverse outcomes, no adverse experiences, there's no detriment to clinical care with virtual care versus inpatient. And so I think that's our next step. We can tell you how many visits you did and how many of this and that, but people really want to know, well, what was the outcome? And I think that's where we're going to start focusing here next. And then the other thing was the cost to deliver care. Can we show that you can use less resources to deliver this virtual care than you do in an in-person visit? So I think those are the two areas that we're going to focus on going forward.
Perfect. Well, thank you again, Dr. McGill, for presenting today. Thank you to our members for attending. Please look for future webinar events on our website at mn.kimschapter.org. Have a great day, everyone.
Thank you.